Hello, good evening. So we're back on Wednesday again with another really interesting topic about manifestations of stroke and what is the relation between stroke and psychiatry actually. This should be useful for everybody, including even medical students. Hello. So I'm waiting for Jaiswal sir. Meanwhile, if you have any questions, please feel free to post. So we'll be answering through the live, during the live. Hi, sir. Welcome back.
Hi.
Sir, am I audible to you? Is it all clear?
Yeah.
Yes. So I want to introduce you to my viewers, sir.
Okay.
So hello, everybody. We have Dr. Jaiswal. He's our chief neurologist from the hospital that I work at, that is KIMS Hospitals, Kondapur branch. And me and sir have been closely working with a lot of patients. We share a lot of patients in between. And sir is a profound believer in psychological manifestations of neurological diseases as well, uh, which is great. We have a great working rapport, and he's a great mentor for me also. Um, that's why I thought, who better than you to talk about stroke, sir? Because stroke is becoming. Someone told me stroke is the new pandemic. It's becoming so common. That's why I thought we should, because a lot of patients, when they come to me, when I ask about stroke, they ask me if it is brain stroke or heart stroke or heat stroke. So they don't understand like what is stroke. Uh, Sir, I got a few questions from through some mails and few of direct messages. Can we start, sir?
Yeah, sure.
Um, Sir, the commonest question: what is stroke?
Stroke literally means something which strikes you, like bolt from the blue. Now, as you rightly said, a stroke could be, commonly people ask what stroke, heart stroke, brain stroke. But the another proper word which we use would be attack. So we talk about a brain attack or a heart attack, which is more common. People understand that very well. Basically, what do you mean by stroke? Stroke is whenever a blood vessel gets blocked, that part of the brain stops working, and that results in some neurological weakness or deficit. So it is a stroke. There are two types of strokes. One is called the hemorrhagic stroke and another is ischemic stroke, to simplify. 80% of strokes are ischemic. That is, the blood vessel gets blocked, and whatever the patient suffers or the neurological manifestations are a result of the area which is deprived of the blood supply. When we say deprived of the blood supply, that means oxygen is lost. So there is a pump failure resulting in the neurological signs and symptoms.
Yes. Sir, so when you say 80% is ischemic, so the 20% is hemorrhagic stroke.
20% of them are hemorrhagic strokes.
So which is more dangerous?
See, a hemorrhagic stroke, the mortality in the acute phase is very high. But if the patient is able to make it for the next couple of days and weeks, once they survive, they have a good chance of living longer. And a ischemic stroke is not life threatening immediately. But again, it also depends on which part of the brain is affected. Suppose there is a stroke involving the brain stem, then there could be death instantly. But most of the strokes happen in the cerebral hemispheres. So there is no immediate danger to life. But if the area of infarction, that is the area of which has got lack of blood supply, is large, that ultimately swells up in the next couple of days, and then the patient starts deteriorating. So in that situation, you sometimes need to do some sort of surgery to create a space for the swollen brain, and then it's a life-saving procedure. It will not do anything for the area which is damaged.
Correct. So, what are the risk factors for stroke? I mean, who can get it? Who are at more risk than other people?
See, stroke can happen surprisingly from our birth to death anytime. Now, commonly it was believed that stroke is a disease of people beyond 65 years of age. But now, if you see the cross section, almost infants could get a stroke. Commonly in infants, the causes are trauma to the brain during delivery, or some sort of infection to the brain, or some sort of vasculitis. And when you come to the adults, the risk factors are slightly different. Hypertension is one of the commonest risk factors. Then smoking, alcohol, trauma. See, all these are the factors which could end in stroke. And in the elderly patients, the commonest cause is a block to the blood vessels. It is something like what they develop in the heart. The blood vessels get clogged. So atherosclerosis is one of the causes for stroke in the elderly. So the causes, they are different at different ages, and the risk factors obviously are different according to the type of stroke one develops.
But
Now,
which
if you,
age? Sorry, sir. Please go ahead. Please go ahead.
we'll come back to that. You could ask me the next question.
Yeah. About the age, sir. So, which age is a little more common than the other age groups?
See, the age has shifted.
Hmm.
Sometime back, the age, it used to be considered as a disease of the elderly, as I told you. So people 50s and 60s who used to develop stroke, till such time we would never consider stroke as a problem in younger generation. But because of the changes in the lifestyle and then addictions and other parameters which have come up now, like with this COVID on now, you are seeing strokes in the younger individuals. So what basically COVID is doing is it is altering your blood parameters. It is altering the coagulation parameters, and people are ending up with stroke in such situation.
Right. So, any warning signs for us to, probably save the patient at much early, early period if they come to us?
Basically, what happens is stroke, if you are talking about the ischemic stroke, we know that this stroke strikes suddenly. So you have to be fast. So the mnemonic is be fast. Now, what is this be fast? Let us look at that. B is for balance. If a person starts losing balance, he is not able to walk straight, he is unsteady, and his arm is swinging, then that is one thing which you should be aware of. Then E is for the eyes. Now, if you lose vision in one of the eye, or you are seeing double, or there is a blurring of vision, then you need to be careful. This could be a warning signal of stroke. The third thing is F, face. So if there is a deviation of angle of the mouth, or if you feel that there is slight drooping of the eyelid on one side, now this could be an indicator of or an early warning sign of stroke. Then arm weakness. If one develops an arm weakness and the arm is numb either and he is unable to perform fine functions with his arm, then this is an indicator of stroke. Now, the other thing is speech. S stands for speech. Now, if one has slurring of speech or is unable to make sentences, unable to communicate, or even understand what others are saying, then this could be an early indicator of stroke. And then terrible headache. T stands for terrible headache. Now, if one has a severe headache, that could be a warning sign. And more so, you see terrible headaches in hemorrhagic strokes. So that way, we need to understand that you have to be fast. Balance, eyes, face, arm, speech, and terrible headache. These are the early warning signs of stroke, and you need to seek urgent medical attention. Because the last terrible headache, T also stands for time. Because time is brain. We had celebrated the decade of the brain, and time is brain was the slogan for that year, for that decade, I should say. So, time, you need to attend to stroke as early as possible.
So, when you say as early as possible, how many initial few hours are more crucial, sir, before they see a doctor?
See, every second you lose 1 million neurons. So time becomes that important when you are attending a stroke. So you have no time. I mean, you should not ask us how much time do I have. You have no time. That is the correct answer. You need to get medical attention as early as possible, because fortunately 80% of strokes are ischemic. That is lack of blood supply. So if you are able to negotiate and restart the blood supply, you will be saving the neurons from dying. So you could salvage.
Right. Right. It's a great revision for me also, so be fast.
Be fast.
Yeah. So are strokes hereditary?
There are a few disorders which are hereditary and they have a higher potency to develop stroke. But by and large, these are seen in younger age group. They could have recurrent strokes and like Mela syndrome and things like that. But they are very, very uncommon. And these patients usually have some other neurological disorder and they will be picked up. But the stroke commonly which we talk about is either ischemic or hemorrhagic. And of course, hereditary pattern is there. I would like to emphasize that the family history of stroke rises your chances of getting a stroke. It almost doubles it. So in that way, a hereditary question I would answer that if you have a family history of stroke, the risk of you developing a stroke is almost double.
Right.
Yeah.
So someone is asking, are strokes recurrent? Do they keep coming back?
Yeah, they do keep coming back. I'll try to give an analogy. Now, if somebody had a heart ailment and he underwent an angiogram and got it repaired, so he got a bypass done. But again, such a person goes back to smoking or is not taking care of his diabetes, hypertension, diet, and exercise. Again, those blood cells get clogged. So there is a high risk of again recurrence of symptoms. So plumbing work, that is clearing the vessels for once or putting a bypass grafting, is a life-saving procedure. But then in the long run, for the nature, you have to take care of those factors which cause the blood vessels to get blocked. So we always say that the passenger, that is the blood vessels, and the passenger, that is the blood itself, these two are important for your system to work properly.
Right, right, right. So someone is asking, if the infant got stroke at birth, okay, what should we do, or do we get to know in TAFA scan 7-month pregnancy? Like, can we get to know this while the lady is pregnant? The child can have a stroke.
See, we are talking, TIFA scan is what you do in those patients. Nowadays, almost everybody gets it done to look prenatally if the child is having any anomaly, any anatomical abnormality. So any imaging pattern you do would pick up an anomaly if it exists. Now what we are talking about, is he going to develop a stroke? Can you predict that? So possibly there are certain anomalies which you look. Suppose the child has some abnormalities like tetralogy of Fallot, or he has some abnormal vessels going into the brain, or if he has got some sort of aneurysms which can be picked up. So all this could tell you that yes, he is at risk of developing some sort of neurological anomaly. So you need to have structural defects or structural artifacts so that you can suspect that, okay, if this is the thing, yeah, this child is possibly at risk of developing some sort of neurological defect.
Right. So someone is asking about, can stroke patients recover fully? It's a common question asked actually.
Yeah. I would like to say that the recovery pattern depends on the amount of damage he has suffered. Now, if it's a very large stroke, then the chances of recovery, they naturally come down. And the more important than this pessimistic attitude would be how fast he has approached the medical help and saved most of the brain. Generally, what happens is we see recovery. In general, it's a commonest question at bedside. We are asked, how much time will it take and how much will he improve? The commonest question they ask is, how much time will it take? How much will he improve is not the question, because everybody wants him to improve totally at that point of time. So the commonest question asked is, how much time will it take? Now, usually we see improvement in 3 to 6 weeks. We have seen patients improving over a period of 3 months also, like patients who have been thrombolized, and then immediately you didn't see the result, but you see the result of thrombolysis maybe up till 3 months of his post-stroke situation. But beyond 3 months, it is unlikely that he is going to make 100% recovery. But again, we have coined the term that activities of daily living. So will he be able to achieve activities of daily living? He by himself is able to take care of himself. That's a big help for the family. And of course, if he's a breadwinner of the family, then yeah, maximum recovery is very, very important in that situation. He should be able to go to his job and resume his work because he's a breadwinner for the family.
Right, right. So, what are the do's and don'ts for stroke patients? Like during the recovery period, what are the do's and don'ts?
During the recovery period, Charan, I think I'll just expand the question.
Yeah.
Do's and don'ts. If you don't want to develop a stroke, we'll start from there.
Yeah.
So we'll talk about the preventive measures, because this is what you have to again extrapolate post-stroke also. So that way it will have more impact.
Yeah.
Now, what are the do's and don'ts? Okay, we'll go back to what are the risk factors of developing a stroke. Now, there are two types of risk factors. Some are modifiable, some are non-modifiable. The two most important non-modifiable are the age of the patient and the sex of the patient. You cannot alter both. They are fixed. Now, the risk of stroke obviously is more common in males. And as the age advances, the risk of stroke goes on increasing. Now, if you talk of modifiable risk factors, hypertension is one important risk factor which has brought down, a good control of blood pressure has brought down the people from suffering from stroke significantly. And in some studies, they say that 80%, some studies they say 50%, or it is at least about 30% risk reduction. So single parameter of control of hypertension reduces the risk of one developing stroke in his lifetime from 30 to 70%. So that's a huge thing. So it's a simple control of blood pressure. And another thing I want to make here is hypertension has also got hereditary factors. If somebody in the family has hypertension, essential, you are a candidate to develop hypertension. And hypertension, we know, is a big risk factor for heart attack and brain attack and many other ailments. So, single most important factor which needs to be taken care of is hypertension. Once we take care of hypertension, the other risk factors, modifiable, is diabetes. Diabetes is a silent killer, we know. Even though we have a good control of diabetes over past 20 years, 35 years, these patients may end up with a stroke in the end because they are atherothrombotic. They develop this. Now, after diabetes, we have the obesity, smoking, alcohol, hyperlipidemia, dyslipidemia, which need to be corrected, because these are the risk factors which definitely cause accelerated atherosclerosis and the clotting and clogging of the blood vessels, and ultimately end up in a stroke.
So somebody is asking about, does diet have any role in probably prevention of stroke?
Absolutely. Absolutely. See, now a favorite slogan is lifestyle modification.
Yeah.
I mean, it's a big umbrella. It's a big umbrella, and we have to take that shelter. There's no way out. Lifestyle modification, where you need to exercise well, sleep well, eat well, and then keep your body weight under control. That is one important factor, because the abdominal girth is very, very important. You talk about obesity, you talk about the abdominal girth, and you talk about the risk such a patient has in developing a heart attack or a brain attack.
Mm. Right, right. Um, Somebody is asking she's asking, my baby is having stiffness in his one hand and one leg. Will he recover?
See, recovery, if we are talking about stroke, depends on the severity of stroke. But here we have a very limited information. The child has got stiffness in one hand. So we need to know the diagnosis. What is the cause for this stiffness? Is it a painful joint, or is it as a part of some sort of a minor stroke which the child suffered in his infancy or neonatal period, and that this stiffness is called spasticity, is a result of that. So I think a proper diagnosis will help us. So it could be any local cause which could cause stiffness. It could be the joint, it could be the muscles, it could be the nerves, or it could be the spinal cord, or it could be an injury at the level of the brain. So a diagnosis definitely will tell us about the recovery.
Yeah. So I would suggest her to probably come and see you, sir. I think that would be better. One-on-one consultation is when you can actually ask more information and you can help the child as well. Yeah.
Definitely.
Um, so somebody is asking if I think this is a medical student who's asked this question. If someone had TCAs, uh, sorry, TIA,
Yeah.
so is it like a indicator that he or she will end up in stroke one day?
See, TIA is a warning signal. It is like a minor stroke. The patient developed a stroke syndrome, and then immediately, because the clot lysed, it burst, then there is no residual deficit. But then if you do imaging, whether it be a CT scan or you do a higher imaging like an MRI, you may be still able to pick up a small clot. It's called a lacune. And the patient may again be absolutely normal in that situation. So TIAs are forerunners of stroke. They are forerunners of stroke. And they are warning signals. So you need to be more alert. And TIA in case of heart, if one has some discomfort in the chest, you always presume that he might develop a myocardial infarction or a heart attack, and you're aggressive. You recommend for an angiogram, and then you do an angioplasty or stenting, or maybe recommend any other thing. So you have to treat his hands an emergency. So any transient ischemic attack is a warning signal, and you need to be alert, because the risk of these patients developing a stroke in another couple of days could be 20%. And then in another 3 months, the risk may go up to 50%. So the risk of stroke in such patients is high.
Hmm. Yeah. Sir, I think I have last question for you. I mean, from my side, viewers can ask more. What is neuro rehabilitation? What all patient has to undergo in the rehabilitation process? Physiotherapy, etc. Like, what is the role of this?
See, once a patient develops a neurological deficit and has difficulty in walking, now natural recovery is one part of it. Now, many a times, let's take an example of simple walking. Now, if you guide them properly, they will, most of the patients, they become wheelchair bound or they become bed bound because of lack of neuro rehabilitation. So neuro rehabilitation is a branch by itself. It has advanced a lot and it has benefited a lot. See, you can see automated wheelchairs which people have. It definitely helps them to move from one place to another in their own house, or even get into the car, or even go to the office. They are unable to walk, but they are able, their brain is intact, their hands are intact, so they are able to do their job. So neurorehabilitation has its own role Neurorehabilitation includes some medicines also, where if there are stiff joints, you try to get them softer. You put them, if the muscles are stiff, you give them some muscle relaxants, and in such way, gait training. Gait training will help them to ambulate very easily in the house. So they would know how to put their foot forward and walk, how to balance themselves, and how on which leg to put the weight and turn around. So these are very finer things which a good physiotherapist would be able to definitely guide you, and it makes a lot of difference in activities of daily living.
So because I usually see a lot of patients, they come to doctors regularly and all of that, but they don't go to physiotherapy. There's no motivation to do it, so they just give up after some time. First month is when they'll do it properly, and then they give up.
Charan, there are a couple of things. What happens is a stroke is a catastrophe. So it is a psychological catastrophe, it's a physical catastrophe, it's a financial catastrophe for a family. Many times they cannot afford to get a good physiotherapy for the patients. They don't have money, because the earning is gone, they're not able to get the medicines also. I think we should understand this. Of course, we can always emphasize on the role of good rehabilitation provided. See, they would be interested in doing that only if he is going to make it. See, any question the patient asks or the attendants ask us, okay, I'll do the physiotherapy, but will he become normal? Now that's a big question. So that needs a lot of understanding, counseling. It's a difficult situation. Prevention is the best thing to in a stroke situation, I would say.
Yeah. So somebody is asking, what are the immediate things a bystander could do in case of a stroke?
The immediate thing a bystander can do if the patient has stroke is time. Get him to the nearest hospital where there is a proper stroke setup and they can attend to thrombolize the clot. That is the only thing he has to do, and that will make all the difference. You don't need to do anything else. Just get him to the hospital where you have all the facilities for stroke management, acute stroke management. Instead of they going for a scan, wasting time on the road, going to smaller hospitals or set up, and then time being wasted in such places. Because as I told you, every minute a million neurons die. Every minute. So every minute counts. So time is brain.
Yeah, true. Well said, sir. I think that's the questions that I have. So do you have any questions from me?
I wouldn't let you go like that. And what is the relationship between stroke and psychiatry?
Yeah. So like you already explained, stroke means a part of the brain or most of the brain is not getting blood supply for whatever reasons. So brain has many areas. Each area has a specific function, or collectively few areas together help in one function. Most of these are physical functions like motor, sensory, etc., etc. Now there are some parts of the brain, prefrontal and subcortical, amygdala, hippocampus. There are many areas that take care of psychological and psychiatric functions of our brain. When those areas don't get the blood supply, patients can present with psychological manifestations also. Yes, but it's not a big rate as the physical manifestations are. A remote percentage would present. Some of them can present with hallucinations, especially if the stroke is in particular areas like occipital area. They can present with hallucinations, auditory hallucinations, visual hallucinations, even olfactory hallucinations. More than the presentation, most of the relation of stroke with psychiatry is after patient had a stroke. Post-stroke deficits include psychiatric components mostly. Like sir, you already mentioned, it is a catastrophe. It takes a toll on financial health, emotional health, interpersonal relationships in the family, and obviously that equates to a mental health at the end of the day. The first commonest thing, needless to say, is depression. We have done a study where in the community samples, we saw 19% of the post-stroke patients went into major depression, which is significant, that required admission and treatment. whereas 9.1%, that's 9% of them went into minor depression, which required only counseling and maybe like a supportive medications, not not like a big treatment plan. That's the first thing, sir. Now, second thing that we saw is if these are the study results that we got when I was in NIMHANS for a while. If the patient had stroke lesions mostly on the left side of the brain, they presented with depression, that to the anterior part of the brain. Whereas the patient had lesions on the right side of the brain, right half of the brain, they presented with manic symptoms where irritability was predominant, hyperactivity was predominant. Uh, that has happened. Now, along with this, the chances of having psychiatric conditions is more if you have a family history of psychiatric problems or if you have had a past history of psychiatric problems. And also, you already mentioned risk factors of alcohol and nicotine. Again, if people after stroke, again, if they go back to the habits, very likely that they'll go into another episode of stroke and also develop multiple psychiatric manifestations. This also includes anxiety, worsening of OCD. This can occur. Along with this, there are some specific conditions that we see after stroke. One of the first thing is pathological laughing or crying. This is when I get the patients saying that without any reason, suddenly, my spouse starts laughing inappropriately in public without no reason. There's no joke on the TV. Nobody has cracked the joke, nothing. Or suddenly they start, crying, weeping, crying spells for no reason. When we ask reason, then they can't correlate to a particular emotion why they're crying or laughing. This can occur. Emotional lability is something that we see again, where they keep switching. Suddenly they'll have like a mood swing. This can occur. Some of the patients, especially the younger patients, they present with apathy. Apathy is where lack of drive and will and motivation. They don't have. The problem is after stroke, to get up and to physiotherapists will come and tell you some exercises and you have to do them. You have to practice things. For that, if you don't have the drive or will, you won't be able to do it. So the recovery will be slightly halted. So yeah, likewise, they won't have any motivation. This is more so seen in patients who are having speech deficits. That's what the like aphasia is what the research has shown. But mostly I see clinical setups, sir. I see depression, I see anxiety. I also see personality change where let me say, I'm a very calm person, very zen kind of person. Suddenly after stroke, I'm getting irritable at everything. Sometimes I can have cognitive deficits. I can have memory, I can have poor memory recall. I won't be able to concentrate on any activity or task given. Even if I'm watching TV, I can't catch up. What is the first scene and what is the next scene? I can have a lot of cognitive deficits. I can be confused. Sometimes delirium also can occur. All this can occur, sir. So this is one of the main relation with psychiatry.
Yeah, you have summarized most of the things. I mean, it is really nice. So what we face is once the post-stroke management, if the patient, as you said, has depression or, and then one is depression, so they don't want any attention or any care. I mean, many of them, they say they want to die. And second thing is rehabilitation. When the physiotherapist comes, they don't want physiotherapy because of the pain. So
Yeah.
they are reactive again. So they become irritable and all that. So these are the challenges which we really face in rehabilitation of these patients. But yes, rehabilitation is very, very important and goes a long way.
Yeah. True, sir.
Yeah.
True. Yes, sir. I think the takeaway message for people is definitely be fast, identifying the warning signs. And I tell a lot of patients that even if you have a doubt that it is stroke, it's better you be safe than sorry. Come to the doctor. If it's not stroke, well and good. Doctor will send you back home. I mean, that's the worst that can happen to you. So please come instead of going to like a diagnostic center, getting your scans, all of that. That will end up a lot of time because I personally know some of my friends, family members, they suffered because they didn't reach the doctor immediately. They kept calling their friends who are doctors and asking, could this be stroke or could that be stroke? Because one cannot tell over the phone. So that's definitely a take-home message, sir, for people.
Time is lost. I'll just tell you one thing. When the thrombolysis came in and the results were good, they were very encouraging. But again, the fear of bleeding in these patients who received this injection was very high. So most of the doctors, neurologists, used to be, I mean, we would be afraid. We would, ask for a CT scan, and if it is hemorrhage, oh, we are happy that it is not a ischemic infarct, it is a hemorrhage. But then, over period, see, the learning curve never ends. Over period, we have realized that even if you have been thrombolized, I mean, it should not be done, but even if you have been thrombolized, if you didn't have a real stroke or a large stroke for that matter, I mean, which didn't require thrombolysis, the risk of you getting a hemorrhage is very, very low. So the thing is, better do it rather than not doing it and then repenting it later. Because by the time, if you lose time, you lose the brain.
Yeah, true. Yeah, true. Sir, someone just asked a question. I expected this question. Is there any relationship between COVID-19 and stroke?
I think it's an excellent and relevant question in this situation now. Now, COVID, we know, is having, it causes derangement in many blood parameters. So we are talking about vasculitis, where the blood vessels, they get inflamed, so they get blocked. We get certain parameters where the blood has an increased tendency to clot. So we have, you look at certain factors like the CRP, you look at the D-dimer. So these are all medical terms. But then these are all telling you that you are going into a procoagulant situation. So risk of you developing a ischemic event is high. So definitely there is a relation. So what happens when you have a patient of stroke? Now, there are protocols where if the patient, they are doing a risk stratification, looking for complications, looking for these few things which I mentioned like CRP and D-dimer, and if these things are deranged, they put them on anticoagulation. They start the patient on heparin, low molecular weight heparin, antiplatelets and statins. So definitely the risk of COVID patients who have a big load of COVID, I should say, developing a stroke is higher. More so if the patient is having a premorbid situation. He's already a hypertensive, he's already a diabetic, he's already a smoker, alcoholic, and dyslipidemic. These are all which are going to double or triple his risk of developing a stroke. Because even young individuals we see strokes developing without any risk factor. So if you have a premorbid condition or a comorbid condition, the risk of one developing stroke is really high.
Right. So somebody asking if you have abnormal sensations on your hands and feet, could that be leading to a stroke?
See, by and large, stroke is a sign and symptom on one side of the body, by and large. Now, if one develops tingling and numbness in both hands, both feet, the diagnosis becomes a differential. Maybe you're not dealing with a brain syndrome, but you're dealing with something lower down. It could be a cord problem or it could be a nerve problem. So that way, the clinical presentation is very important. You need to get a proper history. But by and large, unilateral symptoms like loss of vision in one eye, facial droop on one side, inability to speak, or weakness of one hand or one leg, or swaying when you're walking. So these are the things which possibly tell that the brain, one part of the brain is affected. So if you have something on the left side coming in, you will develop symptoms on the right side. That is the way it presents.
Right. So we'll take last two questions and then we'll wrap up, sir. Somebody is asking, what is stress a risk factor for stroke?
You take it.
I think stress is a risk factor for everything and anything in the world to happen. It might not directly cause stroke, but indirectly it might worsen your blood parameters on a long run, and it can catch up. What do you think, sir?
See, once one has stress, his catecholamine levels are high, obviously. Now, these high catecholamines, they will cause definitely endothelial damage. And it will raise your blood pressure. So you may end up having a accelerated hypertension or hemorrhagic stroke, or a high risk of developing a ischemic stroke, or even a heart attack for that matter. So stress definitely is not good for anything. It is not good for anything in life. It doesn't help you at all.
Yeah.
So stress management, I know you're a better person to answer that question. It needs to be taken.
I tell everybody, if something costs your mental peace, it's too expensive. Like, don't go for it.
Yeah, yeah.
Sir, somebody is asking, can stroke patients have sleep disturbances?
See, most of the patients who develop stroke will have negative symptoms. Most of the patients who have stroke will have negative symptoms. So they are, unable to speak, unable to move, unable to ambulate, and unable to communicate. Now, if we are talking about the sleep disturbance, generally, as I told you, the stroke patients will have negative symptoms and they are bad. Like if he's sleeping excessively, okay, and he's not arousable. So this indicates that yes, he's developed a large area of brain which has been affected. So he's not alert. I mean, we have to assume like that. And once the patient comes out of the acute phase, in the first 3 weeks to 6 weeks or 1 month, then if he develops irritability, is unable to sleep. So I think Charan, you will agree with me. These are all reactive symptoms. He is upset, he is not happy, and he wants to die, or he is not happy with himself in that situation. Because if you lose speech and you are not able to communicate that you are hungry, or you are not able to communicate that you want to pass stools, or you are unable to tell and you pass urine in the bed, so this nobody would want to have in his lifetime.
Yeah. So I think with that we have come to the end. Thank you so much, sir. It was very informative. And I'm sure all the medical students who are seeing should be able to write a 10-mark answer about stroke now without even reading after listening to this.
Thank
That's the goal.
thank
Thank you so much, sir. Thank you for coming. And a lot of people are going to watch it. And the main thing is they have to be fast. There's no other first aid that you can do at home. It's very important. Thank you, sir.
Face, speech, and time.
Yes. So you take
Bye
care of
bye.
yourself. Bye, sir. Good night.
Thank you so much. Bye bye.
Bye.